The use of information on this podcast or materials linked from this podcast is at the user's own risk. The content of this podcast is not intended to be a substitute for professional medical advice, diagnosis, or treatment. The opinions and ideas expressed are those of the hosts and guests and do not necessarily represent the views and opinions of any organizations we may be affiliated with. As always, follow your local protocols. Hello, listeners, everybody out there, all of our EMTs and paramedics in the rural setting. We know we have some med students listening. We know we have a lot of people, different countries. Hello to everyone. I am your host for today. Once again, Phil Leger on the mic, live from Chicago, and joining me, the illustrious Dr. David Collins. How are you, sir?
Illustrious. Oh boy, now we're using really big words.
Yeah.
I don't know if I'd go that far, but I'm glad to be back and visiting with you again, my friend.
And I can edit this out, but happy birthday, sir. I'll save you the song, but I'll sing it to you after we stop recording.
That's probably more appropriate, but yeah.
Got it.
Another year around the sun. Still here. Still got many more to go.
Still doing it. Look at you. Not a day over. Well, we'll leave that detail out.
Yeah, we can leave that out. We're good.
So we have a kind of a fast fire episode, a sort of fireside chat, if you will, with Doc here. And we're going to just touch on a few things. We brainstormed a couple different ideas, and we hope you get something out of it. This is a free form talk, so we're just sort of going to prompt a discussion and then see where it goes. And I think between the two of us, we have a few things to say about what we're going to talk about. So we'll get right into it. First thing on the list is the concept of the EMS pause. And we were just talking about this, but I'm going to sort of lay out why I brought this up. Had a trauma recently, took it to a major urban trauma center, and noticed that the last few traumas that I've taken, there hasn't been the opportunity to come into the trauma bay in an organized fashion, realize who I am talking to and who I should give report to, and calmly and, I mean, for all intents and purposes, as quietly as possible, transfer my patient's care while giving the story of exactly what it is I found and how I found it. And instead, the sort of opposite of all of those things happened, right? 20 people in the room, nobody is in charge, a lot of people ripping things off of my patient and then yanking my board onto their bed while simultaneously ignoring basically everything that I'm saying, right? And so this came up because in Europe, I noticed watching a few shows on YouTube and such in Europe, Canada, New Zealand, Australia. This is a standardized, this is the gold standard, is to give us the EMS pause, right? 10 seconds, 20 seconds, everybody quiet. Listen to what the paramedic in charge or the EMT in charge of the call is saying and get the details before we do anything. Let them unhook their monitoring and their things and prepare the patient to be transferred over. So we're not yanking on spine boards, which we could talk about at another time, but we're not yanking on boards or whatever with seatbelts still attached. And I know there are medics and EMTs, you guys are listening. You've been here. You've been here at some point where it's just like, wow, I mean, I just did a lot of work to get this person here. I have information to transfer over. Is this a thing that we can just sort of make normal, right? Let's normalize the EMS pause. And so I brought this up and I wanted to get, Doc, I wanted to get your opinion on this and where this is sitting on your end of the spectrum in terms of the physicians, in terms of position papers or whatever it is you have on this issue. What say you?
I feel like this is a very unappreciated topic for sure. I mean, if you look at the emergency medicine field in general, I think this is something that's not taught necessarily, and you really are at the mercy of what your institution does. Again, I'm not trying to throw any particular program under the bus, but I would say that for those programs that have a very hands-on EMS director or someone who is board certified in EMS medicine, you're going to have a much better understanding and someone who's much more proactive. So in my case, when we talk about our training lineages, if you will, my training comes from Dr. Josh Stilley, who is a very proactive medical director. I'll give you a for instance that our program, it was very helter skelter. People would just kind of come in and be dropped off. This is my perception. Keep in mind, I'm not can't say this for sure, but this is my perception was things were just less controlled. People would come in, you didn't really know the people, you didn't know the paramedics or the EMTs, and patient was dropped off and off they went. When Dr. Stilley came in, it was okay, you're going to come in, we're going to pause, the physician should be in the room, and we're going to have a handoff. If the patient is actively coding, we will forego that, get the patient onto the bed, start resuscitating, and EMS will still give us some form of feedback, whether that's talking to the attending or to the resident running the code or the secondary resident assisting. Someone is going to get the story so we can make sure we're not reinventing the wheel as we go. So I think that's something that could certainly be taught better in residency training, but I would argue that this is not just a emergency medicine problem. This is a medicine problem in general. And I know that we have a lot of conversations and lectures in medical school now about interdisciplinary training, right? Like we want to make sure that we know everybody's job and what they do. But I feel like someone that's surprisingly absent at this table is EMS. At least when I was going through my medical school training, EMS was not included in that. And so I think a lot of the time we didn't get a lot of their perspective. And so I think we do see some of that bleed too, right? Because it's not just emergency medicine that staffs ERs, rural ERs, you're looking at family practice, you're looking at internal medicine, some surgeons do it. And so everyone's training is really different. What does that look like and how do we make that change? Well, I think from a role perspective, it starts with you guys. It starts with the paramedics and EMTs, right? You need to have a medical director that advocates for you, or at least someone that you can go and say, hey, we're bringing these patients in. The physician, the nurses, whoever is shutting us down and not really letting us give our story. And I think that is probably where I would start with the issue because I feel like that's something that I've been trying really hard to do at my shop is just trying to remind the physician or the PA or the NP that's on call that if you are already there and the paramedic and the EMT have arrived, you should let them tell you what's going on and give them the time to do it. I mean, how many times have you sat and watched someone just start reinventing the wheel in front of you when you could have given them a 30-second blurb and saved everybody a ton of time?
Yeah, I mean, if we're talking about the efficiency of care, particularly in time-sensitive situations, why would you not? And there are probably some reasons for this. You brought up two, actually. Why would you not give that a chance to be sort of like fleshed out? Like, is there a piece of information this other professional knows or has found that I may benefit, that ultimately the patient will benefit from? The two you kind of bring up. One, this idea of a pre-existing relationship. Now, right off the bat, like this is tough, right? I'm coming from the urban center, where there are huge academic emergency rooms, lots and lots of rotations of different various people, and you never kind of really know everybody all at once. However, it's fairly obvious that the guy in the blue shirt or the gal in the bunker gear is probably EMS. Okay, and so I may not know everybody in the yellow cover, gowns, but they know who I am. And that right there, we can start there and go, the basic relationship between the folks that bring in your patients and the folks that, and your team, if you're standing on the hospital side, should at least have that 10, 20 seconds of respect just to say, hey, listen, what is it you got for us? Right? In a calm manner, that 10, 20 seconds is not going to be wasted time treating the patient, right? Save a couple time sensitive situations. It's going to benefit the patient because obviously, wherever they've come from, particularly in the rural setting, we're talking about 2 hour transports, whatever, we've done quite a bit. We've established trends, we've done interventions, we've gone down the algorithms fairly deeply. The other piece of this is communication. Can we just normalize being nice to people? Okay. I don't have to know Dr. Collins to bring a patient into the ER and be like, hey, doc, how are you? Did that take very long? Now I'm going into my story. Okay. And it's not going to cost him anything to be like, hey, how are you? That's it. I mean, really starting off there with communication is huge. And I get that there are tons and tons of stressful situations where you just sort of forget to say please and thank you. But if we just sort of say, hey, listen, we're going to start the baseline where we're going to start is let's try and be nice to each other because we're all trying to do the same thing here. The end goal is to help this person that's in front of us.
And let's unpack that for a second. The fact that just being nice to each other. So let's just give a real life example because I'm all about the real life examples. By the time I was done as a senior resident at Mizzou for my emergency medicine training, I knew most of the paramedics and most of the EMTs. Sometimes there's a little bit more turnover than we'd like by first name. I would greet them. I'd ask them how they were doing. You could tell on the radio who was coming in, right? And I could tell for some of them, if they sounded excited, I should be worried. Like that's the kind of rapport that I had developed with my team. Fast forward, I've been out of residency since 2020. So it's been 4 years since I've been training at Mizzou. Birthday was yesterday, right? I got at least 5 birthday wishes on Facebook alone from former EMS people that I worked with. So I think that speaks a lot to the importance of my rapport with them because I wanted to make sure that I knew them well enough and knew their skills so that if they came in and they told me what was going on, I took that to the bank and I saved myself 20 minutes of time instead of asking all the medication questions, all the medical history questions. They've already done that. They're smart. You've been trained in it, Phil. So I should be able to say, okay, check that, check that, check that. And on top of that, if the patient is conscious and able to confirm, we have a 3-way conversation going on right then and there. Saved myself a ton of time. Don't need to go through that anymore. And I can go right to patient care. I mean, it's not that hard.
And you know what, too? There's a downstream effect to you or to people ripping off my patients' monitoring and their seatbelts and just sort of discarding the fact that I've started 2 lines. They're going to rip those out and start new ones because it's the hospital. These things, whether or not they have some sort of basis in policy or this is how we have to do it. Okay, fine. But these conversations are going to go back to the EMS station, back to the firehouse, back to the volunteer squad, wherever you are. And now I'm going to stand there and just sort of be like, hey, how was that trauma? And be like, I don't know. They kind of treated us like jerks when we showed up at such and such. Really? What happened? Well, it's like they could have got there by Uber and it would have been more interaction, right? That's not the message you want to send downstream. It's not how we want to train med students, interns, residents. That's not the foundation you want to establish. I'm not only talking as a paramedic. I'm not a physician. I'm halfway through nursing school, but I am going to be 40 in October. I'm a grown adult. I'm on this planet long enough to know that being nice and respectful gets you a better kind of everything. Even when it's not reciprocated, you still feel better by doing it. And so we should not perpetuate toxic environments. And the same thing should happen. We should not create a toxic environment that then carries on downstream to a place that's exterior of the place we're in. Right now we have this negative conversation is carrying back to the EMS house, wherever their base is. That's not good.
And I think you're bringing out a good point is the discussion of what do we do with conflict, whether that's nurse A doesn't like paramedic A's medical decision making in the field, and it's now being brought out in front of the clinician, in front of the patient. It just further perpetuates that toxic environment, if you will. One of the things that I've been trying to take more appropriate action in my own shop is just to remind people like, hey, you got an issue. That's fine. Step out of the room once the EMS team has finished their report, talk it out outside the room. Like any backhanded comments, regardless of who it is. I don't care if it's EMS that makes a flippant comment towards the nurses or vice versa. You have an issue, you have beef, take it on outside the room. If I'm there, let me be included in the conversation so we can talk it out and just clear the air. Because the number of times when I first started in several places, to hear the nursing staff roll their eyes or groan when they hear who it is that's going to be responding to that call, that's not helpful because we already have set up a stereotype or perpetuated this idea. This is so-and-so that thinks they know it all. Now if they'd listen to them come in and tell us how they've diagnosed the patient already. Get rid of that. Get rid of that notion because they're doing a job that I can guarantee you that 99% of those people in the hospital setting do not want to do, never want to do. So please don't badmouth people that are doing the job that we don't. And God bless you guys for doing that stuff, because I did the ride alongs. It's some of those environments are terrible. Some of the things you walk into are terrible. The psychosocial situations that you walk into are terrible. In what space should we go and then, shat, shall we say, on our coworkers that are doing that time, sacrificing their valuable time with family and friends to bring these people in from some very terrible situations? This should be a team game. It has always been a team game, even if, let's say, for example, that your ambulance services aren't affiliated with the hospital, or maybe you are. At the end of the day, we're all on the same team. Let's play nice in the sandbox. And if we've got beef, deal with it outside the patient room. Let's get the best care possible done, and then have a sit down, talk about stuff later when the patient, the family, whatever, is not in the room with you.
That's a huge, huge piece. That actual acute sort of conflict piece. Medics, EMTs, nurses, everybody. If you have something to say to somebody, great. But I'm gonna sort of outline very quickly a lesson learned on the law enforcement end just recently. There was a traffic stop. So this is from my law enforcement side. So there was a traffic stop recently in some state where they engaged in this extended sort of embarrassing third grade level conversation between the police officers that were on scene of this traffic stop and these two brothers that had been stopped, who were obviously from the very get-go intoxicated and kind of anti-police, right? And the conversation did not remain professional. It was this sort of like one-upsmanship type of conversation that you would see a couple third graders having with each other before they fight. And it ended up in a couple police officers losing their lives. The suspect lost his life. There was a big shooting, and it was not great. Okay. The end result was not great for anybody. The FBI psychological team took a look at this case and they did an analysis. This person had never, in any of the records that they sort of dug through this person's life, indicated that they were themselves anti-police, anti-government, anti-really anything. They're just sort of a normal person that worked construction who had a lot of exterior stressors, right? A couple baby mamas, another kid was on the way, apparently. Some other things were happening in this person's life, but not necessarily anti-police. They said the deciding factor, the sort of turning point in the interaction, was the fact that the police officer who was sort of responsible for this, who, by the way, was not involved in the shooting. He was not hurt. He wasn't even there. He embarrassed the suspect. He triggered this reaction, this outlandish reaction from this person, because he flat out embarrassed them. Now, I bring that up to sort of illustrate a point. I like to believe them, for the most part, people are very reasonable, particularly in EMS and medicine in general. Like, I love the people I work with. You have your bad days and your good interactions and your less good interactions, but for the most part, I enjoy everybody I work with and I like doing it. But I tell you, you can draw the lion out of somebody for embarrassing them, especially in public, for really no reason. This should not happen. And we should normalize calling out when people do things like this unnecessarily. And I'm staring at Dr. Collins right now. I'm telling you, folks that are local to his region, if you have a problem, this is somebody that truly supports EMS you can go to, and you're lucky to have it, because that's not necessarily the case everywhere. You will not always have PMDs that are willing to go to bat for their people, or who even consider the folks that are on the street their people. And that is a huge thing, and something that should also, so, we really need to look at if we're going to optimize the effectiveness of what we do and how we do it.
I would also add that, being the physician of this, that as a physician, as a physician's assistant or a physician's associate now, I think is what they're called, and nurse practitioners, you are the leaders in that trauma bay. And I think one of the shortcomings in rural emergency medicine is that sometimes the provider is not in house or we're in clinic. I hold myself to the standard, and I'm trying to do better about it, is that if I have an EMS page that goes out, I need to be in the trauma bay or in that ER room when the gurney arrives. I should not be doing my continued clinic care. I should not be doing my hospital rounding. I need to move myself to that area to be a part of that conversation, because sometimes I think that we forget that we need to be the leader. We need to be in that room, not only just to hear the story, so we don't have to hear the patients that they tell the story 6 times, right? Because in rural settings in particular, they tell the story to EMS, they tell the story to the nurse, they tell the story to the next nurse. Then they have to talk to the physician, and by that point, it's for some of them, understandably, they're exasperated. I've told this story 3 times already. Why do I need to tell you it again? Or if there's a med student, why do I need to tell it a fifth time? So let's make it easier. Let's have everybody in the room so that we can all have that conversation. If a concern or a question comes up, it can then be brought forward respectfully, saying, "Oh, I hear that you said that they were hypoglycemic. Why didn't you initiate D10?" That's a fair question to ask in that situation because there might be some reason why. Oh, we couldn't get access. Done. Let's move on. Let's get an IO in. Let's move on with the day. Or in my case, just recently, patient fell multiple feet, head injury, big old laceration, speaks Korean. Rural Minnesota, South Dakota, we don't have a lot of Korean speaking folks. So to get that phone call ahead of time and say, hey, this patient speaks Korean, great. We will have an interpreter up and ready to go. Again, we need to have that open line of communication because if we can be open and transparent and honest, it facilitates good patient care. If we come into the emergency department or we receive an EMS crew in the emergency department with a guarded or almost hostile, in some cases, rapport, the patient care erodes substantially. And I can't emphasize this enough that we really have to get past our own egos, our own biases, and just really come in humble and open and ready to learn. I mean, I feel like that's why a lot of us went into healthcare to begin with, right? Like, regardless of what specialty or what background you're in, we came in, one, we wanted to help people. Two, we're most of us tend to be very avid learners and want to understand stuff. And three, a lot of us are type A, even though we don't claim to be, we don't always admit it. We want to be able to do the best we can. And how can we continue to facilitate that? By actively listening, by giving good feedback, and making sure that the patient takes priority.
Switching gears a little bit. Speaking of learning and, becoming the best practitioners that we can be, we were discussing the availability and the sort of various avenues that we get continuing medical education. Now, I don't feel like I necessarily have that many more opportunities to get CME in the urban environment. I've never been a rural medic, and if you are a rural EMT or medic, and you want to weigh in on this, please, as always, reach out to us. We'll hit us up, like let us know what your perspective is on this. But I wanted to talk to you a little bit about, maybe some of the non-traditional avenues that particularly people just getting into EMS may not know. Like, these things are available to me. This is a way to get CME. I'm going to give you one example of a slightly more non-traditional way that I'm going to get CME next month. Is I'll be shadowing a trauma chief here in Chicago, and I have a 1-to-1 credit with my EMS office for shadowing a physician. It's pertinent to paramedic pre-hospital care. It's pertinent to trauma care, and they've granted me the opportunity to shadow this person and do it. So I'm doing it that way. That's going to be more impactful for me than necessarily, sitting through another PowerPoint presentation. So what are your thoughts on this? Where, kind of where are you getting it, particularly in the now, I don't know, 15-year-old FOMED world?
I think a big point to bring up, and just talking broad strokes of education right now, is we're seeing this huge shift in how students take in information and apply it, right? So, you and I have both were in the era where notes were still taken on sheets of paper with pencils in grade school and high school. Like, there were no computers, there were no laptops, there were no iPads. We couldn't write stuff down like that. So we had our textbooks, we had our notepads, and we wrote stuff. That's just gone at this point. Do we still have textbooks out there? I mean, I see Phil's got the Tintinelli's Emergency Medicine behind him. I've got it too. How often do I legitimately crack that book open and read it? I haven't touched it since residency, to be totally honest. It's great to have. Like if I needed it in a pinch, or if I was going to teach a student, that's where I would go to give them kind of the textbook answer. But does it impact our clinical practice? I mean, I would argue most people that went through paramedic training, and correct me if I'm wrong, Phil, when's the last time you opened your paramedic training book? Like when's the last time you looked through that to educate yourself?
Yeah, I mean, same thing. It's just like no. I mean, by the time those books are printed, you're kind of starting to question whether or not they're really like up to date. We have
Right.
access to the information, like, I mean, almost sometimes, and admittedly sometimes too early. But if you can learn to tell the difference and where to get it, you really can be at the tip of the spear, at least in the knowledge. Like, it's not exactly necessarily at a level of practice changing immediately just because I read a journal article, but my brain is now constantly clicking through some of the things that are being sort of researched. I love that.
Going back to what you said initially there, I mean, we learned something in med school, right? 50% of what we learn is probably going to be wrong at some point. I'm just throwing out numbers because it was arbitrary when they said it, but 25% of it is probably right, and 25% of it's going to be new information. So if you're relying solely on your textbook, or if I've got a EMS member who comes in and says, "Oh, well, based on my training 20 years ago, this is the answer." Well, correct. If you opened your textbook from 1985 or whatever year you started training, that was the correct answer. But I think, especially in the rural sector, we tend to cling a lot to what we learned and not have that open mind about what we can do next. And I'm blessed in that I've got multiple paramedics that are very passionate, that want to understand, that want to know why, which is how this podcast came into being. Was I had a lot of people asking why. But now the question becomes, what changed, in the last 20 years? Like you said, Phil, FOMED has come into its fruition, right? So open access medical education, right? That's where that term came from. But that means that any Joe Schmo can create it too. So that raises your question of what are the good ones? Where would I want my paramedics, my EMTs getting their information? So if I were to just spitball ideas for where I'd want them to learn, I mean, a absolute given would be MRAP, emergency medicine's reviews and perspectives, right? Because these are the best of the best in emergency medicine, basically doing what we're doing now. Sometimes they just wax poetically on a topic, and some of them they go over every single year. Stroke protocols, STEMI protocols. Do we give TPA? Do we give tenecteplase? Like which ones are we giving, and what's the data say? And I feel like that is always a good, safe bet for anyone that's interested in paying that money to get a really good overview of stuff. What else is out there? We've got MCRIT, right? Scott Weingart. He's a good dude. He talks about airway all the time and talks about how we manage really sick patients. I would much rather have my paramedics, my EMTs actively seeking out and getting the information that is clinically relevant to them these days, right? You did the book learning, you learned the physiology you needed to know, but now we need to start unpacking the why and how it's clinically relevant to how we practice medicine today. So those are two of the, shall we say, FOMED podcasting options that are out there. But one of the things that I think that we don't take enough advantage of is what our local resources have too. And what I mean by that is, are there facilities, are there hospitals, are there practitioners that would be willing to help us expand our practice? So I'll give you for instance, one of my sites has been looking into opportunities to do intubation. And there's a facility 60 miles away that is willing to take paramedics into their facility and help them practice their intubations in the OR. There's an opportunity to do something that's low risk in a controlled environment where you can get good feedback from someone who does airway every single day. Anesthesiologists, nurse anesthetists who are willing to work with our paramedics to do some intubations in a controlled environment, which is huge. Like, how
Huge.
often do you get the opportunity to practice airway or even perform airway in a controlled setting? Like, controlled
Basically never.
setting in EMS is an oxymoron. There is no
Yeah.
controlled setting in EMS.
Basically never. And if you're reading, if you're even a little bit into the research, like, this is a thing that is constantly being studied, and EMS is being pointed at as being bad at it, despite the fact that there aren't opportunities to continue to learn or practice this. Okay. Perishable skill, really important. You can't practice it. Also, you're bad at it, and we're going to take it away. Yeah. Yeah.
And I think that's something that, as a medical director, or even as like maybe the director of the ambulance, your job should be to look for opportunities for your EMS crews to grow. And I can speak with confidence that my crews want as much experience with airway as they can. So if we can find those opportunities, we want to take advantage of them. I think being able to think through trauma arrest, like what are the holy crap, poop your pants situations that we can't quite get enough practice with, right? I've been really big on Dr. McCabe. He's a sports psychologist recently about how we are always going to revert back to how we practice in the game time setting. So if you are not doing the effort or the work to really get comfortable with intubation or really know how it works, you're going back to the worst practice or your best practice situation, which may not be great. It may not be great when it's game time.
Yeah, you gave a couple of really good resources there. The thing that I really love about those two resources in particular, I found personally that if you sort of, not in a bragging way, but if you happen to find yourself in a conversation with somebody and they're asking you like, "Hey, where did you get that information? Where did you get your information?" And you're like, "Hey, I was listening to MCRIT, I was listening to MRAP, I was listening to, Core EM or a few of the other really hard hitting ones." That is the same content medical students and residents are listening to right now, right? You have access to the same level of information. Now, granted, some of it may be at a level and sort of down the stream of treatment for a patient or a disease process that is past what is applicable to paramedic treatment in the streets. However, it does feel anyway that it sort of like levels the playing field a bit in terms of those conversations. And I think just from a psychological standpoint, that's so important. You should not feel afraid to talk to a physician that you're working with and handing over a patient to. I regularly go back to my physicians and be like, "Hey, do you have anything for me on this run? I just wanted to see if you had any comments, something we should have done better, something we should have done differently." And a lot of times, I get the like, "No, I thought that was great," but they're teachers and I'm giving them the opportunity to show them I'm okay with being a student. I'm okay with learning from you. A couple that I like, MRAP is great. If you can get access to it, MRAP's Grand Rounds series focuses more on like the urgent care piece. And there's some sort of like slightly lower level emergency, urgent care type presentations of things that you may well get 911 calls for. And having knowledge of those things, that's huge. The other one, and this one came out of left field at me. I was searching for emergency medicine on podcasts, Apple Podcasts, whatever. And then I forgot to type emergency and it just typed medicine and filled in family. And I found the Frankly Speaking podcast. I'm going to shout out to Dr. Domino out of UMass. And it's a family medicine podcast in 10 to 14-minute segments about things we deal with all the time as paramedics. Well, my blood pressure was high because my CVS blood pressure monitor said it was. My blood sugar's high. I think I need an antibiotic. I've had a cough for 2 days. 2 whole days? You know, this is stuff that like sometimes often gets thrown at us either from friends and family or on 911 calls or wherever. The community just has a question, right? And it gives you solid ground to at least have some knowledge of what is the latest. And the family medicine folks, the internal medicine folks, Core IM's another one. These are great resources to bone up on the things we see chronically: hyperlipidemia, diabetes mellitus, high cholesterol, high blood pressure, all of the things, right? This is a great way to do those things, and you can do it, and they're well done.
I think the other thing that in terms of rural is less accessible, but that we should definitely remind people about is being active in your respective chapters for relevant organizations, right? So ASEP, the American College of Emergency Physicians, going to that here in the end of September. Really excited to be going to Vegas to relearn a lot of stuff that, we just don't think about. It's basically like super residency, in my opinion. There's always topics that I can learn stuff about, take some pearls back home. Like, oh yeah, that's how I manage this really random presentation that very rarely comes in. But, there's going to be your EMS equivalents of that too, right? So, NAEMSP, I know that they like having paramedics as part of that group because you're part of that process. You're part of what makes EMS physicians have a job. And how we can learn is by having our EMS colleagues being there to say, hey, these are the problems that we're having in our rigs. What are you as the EMS physicians going to do about it, right? You've got your state chapter, right? We've got one coming up in Duluth in October. I'm going to that one. I think our ambulance directors going with us. Like, taking advantage of these conferences is not only an opportunity to learn, but it's an opportunity to visit with people from adjacent agencies or agencies from another state and just say, hey, we're having a problem with X. How are you going about fixing that? Or, oh, that's interesting, we do this. How do you manage Y? And you have these great conversations that then you can take back to your medical director or whoever and say, hey, I just went to this really great conference on crash OBGYN. Very, very uncommon. But they talked about some of these interesting things that we could do in the field. What are your thoughts on that? That's the stuff that I want to hear from my paramedics and my EMTs, because if they're out there actively trying to engage the material and go above and beyond, not only does that elevate their understanding, it pushes me to elevate myself to a level that we can meet the need of patients in our community. Now, sometimes is that within our budget? Probably not. But then we can at least start having those conversations to figure out, how do we problem solve that? How do we make this affordable from a rural EMS perspective? How do we do this so that our EMS services are just as good or as good as they can be in comparison to Chicago, for example? Like, how can we elevate ourselves so that the patient has just as good of an outcome?
And, being involved in that process also gives the creators of this educational content the ability to expand the utility of the information to the folks that are going to use it. You bring your experience to this development, and now the education is suited to you, but also you've contributed because you know how to do it best in the rural setting. You know that you're adding to this sort of body of work with your experiences. We're like, well, that's a great idea. In the rural setting, we would have to do it this way. As a creator of educational material, I'd have, maybe that's an opportunity for me to rethink a couple things and go, okay, well, you know what, to make it more applicable to more people, thank you for that information. Now I'm going to expand it in this way. That's huge.
And I got to be that guy at the National EMS Physicians Conference 2 years ago, because I sat through the EMS medical director's training because I wanted that extra information. I wanted to learn. And what's really cool about that, for those of you out there that are aspiring medical directors, go take this course at NAMSP. It's fantastic. I might take it 2 or 3 more times just to really get all the material down. But I got to be that guy, right? Because the people that generally take this class are EMS fellows that are going to become board certified EMS physicians. So they're expected to take this course because it's just kind of a refresher for them. It gets them more excited, gets them engaged with people from across the US. I got to be the guy that sat down because the way it was set up is we had a bunch of lectures, but then we also had these scenarios that we had to walk through. And almost on every occasion, I got to say, okay, well, I don't have that. Nearest thing for that is 60 miles away. What am I supposed to do, or what can I do to elevate my EMS crews? And just seeing the blank stares that I would get from the EMS fellows, it made the facilitators just giggle sometimes, because they loved it, because they like seeing the fellows struggle a little bit. And I wasn't trying to be a jerk. It was just like, hey, yeah, you're talking about inner city New York. I don't got that. Like, I've got, on a good day, an EMT and a paramedic, and that's all I got for like 60 miles. So I can't do that. What else you got? Or what other solutions do you have for me to make sure that, we provide the best patient care we can with the resources we got? And I think that benefited both of us in that regard, just to kind of think a little bit outside the box. And I remember getting some reactions of like, I can't believe you do that. Like, how do you manage those people in rural EMS? It's like, well, you take the resources you got and you run with it.
100%. And just putting on the emergency manager hat for a second, there's an argument, and we saw this during Katrina, we saw this during Sandy. There's an argument for everybody, rural or not, to be prepared to do it a whole different way, to know how they do it. How do you survive when when you are resource limited? Because you can very quickly become resource limited, and you're going to have to think outside of that box. There's great footage from the Moore, Oklahoma tornadoes. Then it was a camera crew following a medic who then actually later on became a physician. Family practice, not emergency, which I thought was interesting. But he was by himself in like a high school gym with 50 patients and, like, I don't know, 13 concurrent arrests coming through the door. Right, extreme situation. But the equipment he had amounted to whatever he could pull out of the back of his ambulance in terms of bags and equipment. And then the rest of it was destroyed. Now what? Right? How good are your triage skills? How good is your ability to tell somebody to do something simple medically that can help somebody else? Delegation, scene management. That stuff we carry. I don't know. We spend about a couple hours, chapter 1 and chapter 2, when you start EMT school or paramedic school, scene safety, BSI, and we're gonna manage. This is EMS operations, and then we go on to the stuff we think is really super important. Well, guess what? This other stuff can get really important really quickly if you put a good sized hurricane on your city, like New Orleans found out. You know what I mean? So, yeah, absolutely. In terms of the information coming out at the conferences across the United States and the new things that are coming out and keeping up to date, like we are both talking about, I wanted to ask you about whole blood and whole blood in the rural setting. There's a lot of discussion around whole blood. We've talked for years about component therapy and trying to figure out, like, well, normal saline over lactated ringers. No, 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 no. Lactated ringers, this is where it's at. Fresh frozen, or, the host of different products that are available. And kind of the conversation always comes back to, well, the best thing would be whole blood. Yeah, but we can't do that. And conversations have ended on less. Like they sort of kind of end there, and then you leaves you scratching your head going, well, if this is the best thing, how is this something we haven't figured out? And you mentioned to me that there was some movement on this. What is happening?
Keep in mind that a lot of what we learn, a lot of what we apply in civilian emergency medicine, civilian pre-hospital medicine is based on battlefield medicine, right? There's not a lot of data, or at least not a good way to collect data for the traumas, whether they're penetrating, blunt trauma, whatever, unless you're a level 1 facility, but that doesn't necessarily even get you the numbers you need then. And you can't necessarily ethically perform studies on things like whole blood necessarily in some cases, because if we already have something that's meant to save lives, should we really be monkeying with anything else? That's part of the questions that get raised. So this is where we enter battlefield medicine, right? Humans have been fighting each other for centuries, and it's probably not going to end anytime soon. So this is actually where the whole blood conversation started again, is that our units in Afghanistan and Iraq and, in more recent wars has gone back to that question of, should we be using whole blood? And what's the thought process behind that, right? If you think about what we're doing right now, Phil, like when you get a massive trauma, like a terrible trauma, you're calling ahead and you're asking, or you're warning them so they can initiate the mass transfusion protocol, right? What does that look like? What are we giving people in that case? Well, the Red Cross has supplied that facility with X number of platelets and red blood cells and plasma, and that's what you get. And we've got these protocols, and you got to give 3 units of this, and you get 1 unit of that, and then you got to recheck their enzymes and their coagulation factors, and you can do da 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 down the list it goes. I mean, when I was a resident, we were still doing those protocols, and they're still in place. Like we're still doing those 3-3-1-1 rules, or whatever the rule is now. I can't remember because we don't do it in a rural setting. It's a very confusing formulaic process, and I think only our trauma surgeons and the trauma fellows really understand it in its entirety, to be completely frank. Maybe some of the residents that really love that stuff know it really well. I never really got the hang of it, just because it was just kind of so complex in my head. So imagine this now in the military setting, right? Are we going to be able to reasonably and logistically have all those products readily available, especially in a mass casualty event where an IED blows up, right? All of a sudden, you're going to have to try to figure out all those things, hope you have enough for every single soldier that got injured. That's not really practical or realistic. I mean, what did the soldiers do in the battlefield? They've got their blood types on them, so they can give each other whole blood. And so that raises a whole new host of problems, right? Because we talk about, with like blood transfusions, platelet transfusions, we talk about these reactions that our bodies have. But for some reason, whole blood seems to work just as well, if not better. And they've been doing lots of studies on this recently. I mean, there was some studies in 2022, one called "An Impact of Incorporating Whole Blood into Hemorrhagic Shock Resuscitation," analysis of over 1,000 consecutive traumas with emergency release uncross-matched blood products. That's from the American College of Surgeons. And they just looked at that question of, what do we do if we give people these whole blood products for, I think it was about 3 years they did it. They did all their stuff and they did their studies, and just mainly looking at, what was the survival rate? Did people do better or worse? when they look at this stuff, you want to ask the question of, did patients that received whole blood do just as well, right? We're talking about non-inferiority trial in that case, right? We're asking the question, we don't want to have something that has worse outcomes, but it doesn't have to be better, right? Like if we can make this simpler, if we can make the trauma scenario simpler, if we can initiate blood products in the field as an extreme example and resuscitate the patient better, then why aren't we making this transition? And so the study that I mentioned, whole blood was associated with both improved survival and decreased overall blood utilization, right? In the mass transfusion protocols, you were firing through all these packed red blood cells, platelets, et cetera, et cetera, et cetera. And you're just burning and burning and burning through this stuff. And we have a massive trauma. You're going through 10 or 12 units of blood, if not more. And once they go to the OR, you're dumping even more into their system. So effectively, the whole blood has everything you need, and we can all put it in there at once and really save ourselves a couple steps. That's the thought process. And that's why we're seeing more of these journal articles coming out making that argument for whole blood. But now we have to enter into the question of logistically, is that doable? And I feel like I need to do a little bit more research as to like, how does that work from the, American Red Cross? Like, how achievable is it to just have whole blood readily available? Like, how achievable is it for a rural setting to have whole blood available? And I know that Dr. Antevi in Florida just had a presentation for, I think, the Florida NA EMSP chapter about this. Like, can a rural facility or a rural EMS group have whole blood, and does it make a difference or not? And I'll have to do some more digging on that end, but I would be very interested to see and hear what Dr. Antevi found in that case.
Along those same lines, Doc, and just to kind of finish this discussion up, the science has come in hard and fast at us. And after what feels like forever, the American Heart Association is planning to have their scientific conference November 16th through the 18th here in beautiful Chicago. What are your predictions for the future of, and most pertinent to us, the out of hospital cardiac arrest algorithms and protocols that we currently know and love? And if you just had to sort of like guess, what do you think this looks like in the next couple of years?
So I'm going to tread lightly.
I was going to say, because like I've heard, like for instance, like, and we could edit whatever we need to, but a while ago, this is years ago, a couple years ago, Phoenix was doing, I think, high flow nasal cannula or non-rebreather mask only. So no ventilations. They did a bunch of studies with that. I don't know where that stuff went. A lot of people have been talking about passive oxygenation, in particular, peri sort of intubation, that kind of thing. The iGel came into favor. It was super good. And now you're hearing rumblings of some CO2 trapping. After, a host of very respected people was like, yeah, it's a definitive airway. I mean, there are a lot of things that go into this management. We're still trying to figure this thing out. And, I think, unfortunately for a lot of medics, particularly in my realm anyway, ROSC is somehow the gold medal here. Like, hey, not exactly. Okay. Like, I know it feels good to sort of be like, we got ROSC. Like, let's take that a little further. I think we're in a place now where we have access to enough information and experts that we can be like, all right, let's set the bar a little higher here. 30-day survival,
at the point.
60-day survival,
Right. The 30-day, 60-day survival is important. But the other thing is like neurologically significant outcomes, right? We always talk about like, did the patient's brain function survive? Because if the patient's brain took a serious hit due to the lack of oxygen, then was it really a meaningful resuscitation? Because now you've just created a whole bunch of new problems where the patient is a vegetable and the family now has to pay hundreds of thousands of dollars for this patient to be in a nursing home or in an ICU until they decide to go comfort care. And I'm not trying to be harsh about it, but like that's the reality we live in, is that we want to have clinically significant outcomes with neurologically preserved patients. That I think is the hardest thing about, the American Red Cross recommendations versus the AHA guidelines, is that they have to do study upon study upon study to move stuff, right? 10, 15 years ago, lidocaine was all in vogue for the ACLS protocols. Gone. Some people still dabble in it though, because the advanced practitioners, the people in emergency medicine and cardiology, because they know the relevant data in that case. But as far as like the family practice doc or the ones that are doing ACLS in the sticks, they have these guidelines in place to keep it as simple as possible, because the data that they currently have supports X, Y, and Z. But when you look at the data, sometimes even with epinephrine, it's not great. right? Like, what is the one thing that always saves lives that we get taught in our BLS and our ACLS classes, right? Good compressions. That's the end of it, right? Unless we get good blood flow around the system, it's a moot point. Epinephrine is not going to function if you're not getting good compressions. They did some studies looking at, and I love this, esophageal ultrasound, right? So there's in these big trauma centers, during a cardiac arrest, someone snaked down an esophageal ultrasound to get a good window of the heart, which is awesome. I saw some videos of it. And what they were doing during their resuscitation was making sure the heart had good compressions. And if they were not getting good compressions, they would tell the compressor, move to the left, move to the right, move down until they got good compressions. And they found that ROSC was achievable when you had a good location. But we don't have that. That's not feasible in the pre-hospital setting or in the rural setting. Like, I could try to pitch it to my superiors, but they would laugh in my face about having an ultrasound that's capable of going into the esophagus. Come on. It's not doable. But
Yeah.
it really hits the point home, right? At the end of the day, good compressions is what saves lives. Now, at some point, I've been seeing a lot of studies on Narcan, naloxone, right? How many of these arrests are opiate induced? How many of these arrests are related to someone's recreational or prescription drug use, right? So there's a lot more push about you have an undifferentiated arrest, push naloxone. There's nothing wrong with that, but it's not in the AHA or in the American Red Cross guidelines yet. So at the end of the day, it's all, and this is just from what I understood and from reading the literature and, learning as a resident, is that to change these national guidelines, it takes a ton of data to either prove something or disprove it. Case in point, like, is lidocaine doing anything? Nope. All right, well, then we're going to dump it from the guidelines. Like, and it takes a long time to mount that evidence, and it takes a lot of really smart people to sit down and say, okay, based on the 50 meta-analyses that we've run on this, is naloxone something that we should add to that protocol? Who knows? Maybe that's something that's going to get pushed. I'm just saying, because I've just seen more journal articles and more chatter on social media from our EMS colleagues from different, podcasts and whatever, that are saying, push naloxone. Why not? Sounds like a great idea. But to have the AHA or Red Cross sign off on it, that takes a lot more work, and it takes a lot more reviewing the data. This is why we have not only the national conferences, but the international conferences, right? Like, where we have people across multiple countries sitting down and saying, okay, our protocols are similar in these areas. Are there any discrepancies across our protocols where we're seeing an increase, not just in ROSC, but in, like you said, 30-day, 60-day survival, and as well as neurologically meaningful outcomes? And I think that's the thing that makes predicting how this is going to go really hard to say. But if there's some really compelling literature that, inspires these cardiologists, intensivists, cardiothoracic surgeons say, we want this, I can guarantee you it's going to be very much evidence driven.
Okay, so I'm going to press you really quick in our last couple minutes of the podcast here. Does Epi survive 15 years from now?
Ooh, 15 years from now?
10 years.
Oh, boy.
Does the administration of Epi at the 3 to 5 minute mark survive?
I think until we have something else come along that's different, I think it will, to be honest.
Okay.
And I think part of that has to do with risk benefit, right? Like, patient's already dead. So pushing Epi is not going to make them any more dead in that case. And that's one of the arguments I've heard with, like, anaphylaxis, right? Like, if they're actively dying from anaphylaxis, give them the Epi no matter what their vital signs are, because you aren't going to reverse it. So I think unless we see, like, another drug or another, intervention come along that is superior or non-inferior to epinephrine, I think that's there to stay until we've got different evidence, or we see evidence that says epinephrine is harmful, which we've started to see a little bit of that coming out, saying, well, maybe there is something to it.
I got a next one for you.
All right, next one, fire away.
Elevation of the head of bed to facilitate venous return. 30 degrees. Thoughts?
So thinking about this again from big picture, right? So if I'm thinking pathophysiologically, it makes sense in my head, right? Like, if you elevate the bed, it's going to help facilitate that. But does the data support it? That I'd be very interested in seeing, because it's something that, we read about, we talk about it. It makes there's a lot of things we talk about in medicine that make physiological sense, right? It's kind of like that whole debate about medications and COVID, right? There are some people that thought mechanistically certain medications were going to treat COVID. Great in theory, but the data didn't pan out. So I think that's kind of the same thing, is that I would much rather see what the data is based on the physiological evidence, right? Like if the physiology makes sense, we should be doing it. But if the data says not making a difference, or if this is hurting the patient, we're having bad outcomes, or ROSC isn't happening, or the neurologic outcomes plummet, bye-bye.
Okay. And along the same lines, the answer might be the same. I heard some chatter of some studies that were talking about transitioning the positioning of compressions to sort of cheat the left side of the chest to potentially be more center to the heart muscle itself. Thoughts?
That makes sense to me. I mean, like we talked about when we talked about the esophageal ultrasound, physiologically, if you can see where the heart is and you can compress, that should be your target. I would also be very interested, because I'm guessing there's probably studies now for those of us that are ultrasound nerds. If I drop the probe on the chest just to find like the apex or the best part of where I should be compressing, my hands go there going forward to just see if it works. Because we know that physiologically, everybody's different. The patient with CHF, cardiomyopathy, COPD, the heart's enlarged, it shifts. Like for those of us that try to do a lot of echocardiography, our biggest nightmare are the patients that have smoked 100 packs for the last couple of years, or the patient who's had multiple infarcts or have had progressive CHF, because the
Oh, we
heart
don't do
isn't where
CPR
it
on those
belongs.
people, Doc. That never happens.
It's always the young and healthy 18-year-old
Yeah,
athlete
of
that
course.
needs the
Right.
chest
Yeah,
compressions,
exactly.
because that's going to
Yeah.
be right where it belongs. So yeah, I think
Well,
that definitely has some credence for sure.
yeah, big fan of POCUS. And last word on this one: use of ultrasound when you have PEA arrest.
Do it. I love it. I think it's important. I mean, I incorporated it into all my cardiac arrests towards the end of my towards the end of my residency, because it just made sense. Like if I have a second of pause while they're doing lines or whatever, we're doing a pulse check, probe subxiphoid or peristernal to see if you got a heartbeat, right? If I see meaningful contractions and I know we're getting close, we just got to make sure they get the pressure up. If I see quivering or nothing, then that gives me a better idea of how long it's been going on. Or more importantly, because I saw this in residency, if I start seeing these swirly little patterns or like this grayer material sitting in there, that tells me that we've got blood congealing already, meaning that patient has been down for a significant period of time. So that actually really does help me drive my resuscitation. And what's more, as a attending in a rural setting, I've had several cardiac arrests where family was there, and I could demonstrate for them during pauses saying, this is their heart. You can see it's not contracting. You can see there's blood pooling and clotting in their ventricles. Even if we get them back now, they're going to risk throwing clots to their brain, the rest of their body. This is not a good idea proceeding. I think it doesn't just change our practice in terms of pre-hospital and hospital, but it changes the way we have these conversations with patients. And there's some situations where we're told bring the patients in, or bring the family into the room so they can see. And sometimes they want to see it. Another time there's times where the family doesn't want to see it. But again, I have that additional information to go and say, hey, we're still resuscitating right now. They're doing the protocol, what we're supposed to do. I'm coming out to tell you that this is what I'm seeing on my ultrasound. This is what we've seen after giving 18 rounds of epinephrine, giving them, amiodarone and a couple other random medications, and we're seeing no change. I would recommend against proceeding. And I think that really does help not only facilitate patient care, but also how we have those tough conversations with family in really tough situations.
Medical family, Dr. David Collins, giving up his sleep, time with his family, sacrificing for our benefit. Thank you, sir. We do appreciate it.
Or just visiting with you on his day off. Let you decide which one it actually is.
This is actually a normal conversation that he and I just have for fun, and then we decided to record this one. That's kind of how these things go, which we've figured out. This is kind of what we do. So we appreciate y'all joining us for our chat, and hope you got something out of it. If you have questions, please email us and reach out to us. Obviously, follow us on all the socials. Give us 5 stars on the iTunes or wherever it is you get your podcasts. And as always, we do appreciate you. So keep doing the good work you are doing, and thank you.
Thanks, everybody.